Now move to the second presentation, and we hope for a similar fascinating discussion. And this is a case of chronic indolent pheochromocytoma, which caused medically controlled hypertension but treatment-resistant diabetes mellitus. And we have, this is presented on behalf of Doctors Lee, Park, Na, Kim, Lee, and Park. Please.
Thank you very much. Good afternoon, everyone. You must be bored to see pheochromocytoma might be too easy to be presented in this situation. But for me, it took 9 years from first meet this patient and final diagnosis. And when I heard pheochromocytoma from preoperative consultation, I was very embarrassed and shocked because I did somewhat risky procedure to her. So please hear our case and think and tell us which time you can diagnose pheochromocytoma from this patient.
Hello, it is an honor for me to be presenting at the ISH. I am Hyun Lee from Seoul National University Hospital. Our patient was a 47-year-old female, and she visited the emergency room on 2006 March. Her main complaint was dyspnea, which started 2 months ago. She was a previously healthy woman, and 2 months ago, after upper respiratory infection symptoms of cough, myalgia, and epigastric pain, dyspnea of NYHA functional class 2 to 3 developed with intermittent chilling sense. She was managed at the local clinic for asthma, but she had no improvement in symptoms. 1 month ago, she underwent operation for anal hemorrhoids, and she bled rather severely and received transfusion. 3 days ago, before the visit, her cough and dyspnea aggravated, and she went to the local hospital and was diagnosed with possible heart failure and was referred to the emergency room. She had nothing special in her past medical history. She was a housewife and she did not smoke or drink alcohol. She had nothing of interest in her family history. On interview, she had general weakness, easy fatigability, and she had anorexia and indigestion, and she had some weight loss. She had cough and dyspnea, which aggravated on supine position and on exertion. On physical examination, she had normal blood pressure at 129/86 millimeters mercury, and her heart rate was slightly elevated at 113 beats per minute, and she was breathing rather fast at 22 times per minute. Her body temperature and oxygen saturation were normal. Her height was 161 centimeters, and her weight was 67 kilograms, and she was overweight. She was slightly anemic and icteric on examination, and she was not dehydrated. On auscultation, we could hear coarse breath sounds with crackles on the right lower lung field and rapid heartbeat with a soft systoling murmur. She had a soft, flat abdomen without any tenderness and no visible edema or cyanosis. This is her initial laboratory findings. On ABGA done at room air, she had a normal O2 pressure, and she showed signs of hyperventilation. She had slight leukocytosis with a normal segment fragmentation fraction, and her total bilirubin was elevated at 2.6 milligrams per deciliter, and her liver enzymes were elevated at 930 units per liter and ALT 1,868 units per liter. Her PT-INR was elevated at 1.59, and her urine was rather concentrated, and albuminuria was 2 positive. Her BNP level was 2,002 picograms per milliliter. Her hemoglobin A1C level was 6.8%, and her fasting blood sugar was 142 milligrams per deciliter, and she was newly diagnosed with diabetes mellitus. Her thyroid function was normal, and her hepatic serology was normal. Her initial chest X-ray showed cardiomegaly and pulmonary congestion with right pleural effusion. Her initial electrocardiogram showed sinus tachycardia with ST elevation at V1 to V3 and ST depression at V6, suggesting a left ventricular hypertrophy. Her initial echocardiogram was as follows. She had dilated LV cavity with an end systolic dimension of 61 millimeters and end diastolic dimension of 72 millimeters, and her wall thickness was normal. She showed secondary mitral regurgitation due to tethering, and her ejection fraction was decreased at 28%. There was global hypokinesia, as you can see. A myocardial SPECT was done to check for cause of heart failure, and there was no significant perfusion decrease, suggesting ischemic heart disease.
Yes, from this point until this point, I think I thought this patient is the usual dialytic cardiomyopathy who are aggravated by upper respiratory tract infection. Because although she has newly onset diabetes mellitus, EKG shows the ST elevation and reciprocal change. We rule out coronary artery disease presence by SPECT, but there is no specific regional warm motion abnormality. But now in this point, we know the final diagnosis. So if you check the clinical manifestation of pheochromocytoma, one of manifestations is heart failure with hypertension that comes from direct myocyte injury. And typical pattern of LV dysfunction is Takotsubo cardiomyopathy. But as you see, this patient is no sign of Takotsubo, but a global dysfunction. So in this point, my diagnosis dilated cardiomyopathy aggravated by urine infection. So initial assessment is dilated cardiomyopathy and congestive hepatopathy and diabetes mellitus. So we treated him because her blood pressure is low. We made dobutamine, and he got the improvement of symptom. At the time of discharge, BP, blood pressure is 90 to 74, and pulse rate is still high. So we started carvedilol without covering any alpha blocking agent. So we made inotropic and beta blocker and full heart failure management. So in this point, I want to ask how was this patient safe with inotropic? So we all know sympathomimetics may stimulate catecholamine release, which may be very harmful to the patient. But however, long-term chronic exposure to the catecholamine make desensitization, so make little impact for further increase in catecholamines. So I did not do on purpose, but I made many mistakes. So how is the chairperson's opinion? Can you detect the pheochromocytoma at this patient?
Okay, so this is now open for discussion, and we hope we'll have some discussants coming to the microphones. Clearly very difficult, but as you told us at the beginning, pheochromocytoma is a great mimic, yes? And I think you've just discovered this patient at the time where this great mimicry was already very advanced. I presume this pheochromocytoma has been present for quite a while, and that's why dilated cardiomyopathy, the distractive changes of cardiomyocytes due to excess of catecholamines, which you haven't measured yet because blood pressure was completely normal or low. So any ideas, any suggestions from the audience, please? I know it's late, but we need your help. No? So I think you explained everything, so could we hear a little more?
Yes.
I will tell you about her outpatient clinic course. Her blood pressure and pulse rate was normalized at the outpatient clinic, and she was kept on carvedilol 6.25 milligrams twice daily, losartan 50 milligrams daily, and toracemide 5 milligrams daily for around 2 years, and she was quite stable. On the second year, her blood pressure started to increase and nifedipine was added. Also, her blood sugar levels were started to be a little high and were not improved through lifestyle modification, so metformin was added. On the 2-year follow-up electrocardiogram and chest x-ray, you can see diffuse team version on her electrocardiogram, but her chest x-ray shows improvements with disappearance of cardiomegaly and pulmonary congestion. Follow-up echocardiography was done, and her LV cavity size was normalized, and her ejection fraction was recovered from 28% to 73%. Secondary MR disappeared, and her ejection fraction was normalized, but apical achinasia was still left. As we continue to follow her up at the outpatient clinic, her blood pressure and pulse rate and hemoglobin A1C levels started to slowly rise. Blood pressure medication was changed to amlodipine plus valsartan, and sitagliptin was added, and then the dose was increased. Carvedilol was initially discontinued due to concern that it might aggravate hyperglycemia, but she showed increase in blood pressure and pulse rate, so bisoprolol 2.5 milligrams daily was added again. Her blood pressure was stable with that medication, but her blood glucose levels continued to rise. On the 5th year, her glucose levels started increasing very steeply, and her HbA1c suddenly rose up to 9.3%. So glimepiride was added. After 3 months, hemoglobin A1c levels decreased once more to 7.3%. During this time, the blood pressure was stable. At 5 years, we performed another follow-up, and her electrocardiogram was totally normalized, and her chest PA was normal. On the echocardiography, you can see that the function was continuously normal, and the cavity size was normal, and also apical achinasia disappeared, and there was no regional wall motion abnormality. At the outpatient clinic, blood pressure continued to rise and started rising once more, and we added thiazide and spironolactone, and then increased the beta blocker dosage to carvedilol 25 milligrams twice daily. Hemoglobin A1c levels were stable on metformin, sitagliptin, and gliclazide, but rather high at 7.7%.
When we screened secondary hypertension, pheochromocytoma always maybe first one to rule out, but in real, pheochromocytoma is an uncommon cause of secondary hypertension. Only 0.2% of all hypertension patients, and even resistant hypertension, the prevalence is 1%. But in contrast, among pheochromocytoma patients, majority have sustained or paroxysmal hypertension. It cannot be discriminated clearly, but there is subtle difference in hypertension pattern according to mainly secreted catecholamine. Noradrenaline dominant type, it may increase peripheral vascular resistance, so sustain the hypertension usual phenotype. But adrenaline dominant type, it may increase cardiac output, so episodic paroxysmal hypertension is more common. So paroxysmal hypertension, majority occurs at least weekly and generally lasts for several minutes to 1 hour. Patient from time to time in my outpatient clinic, she complained headache, but she didn't take his blood pressure in their home. And every time she visited my clinic, blood pressure is in predictable range. So in this point, still I cannot catch whether headache is some episodic symptom of pheochromocytoma. In this point, we think beta blocker, we all know beta blocker is very dangerous because beta blocker should never be initiated until there is sufficient alpha adrenaline blockage, because block the beta-2 adrenaline receptor make impaired vasodilator function, then make further increase in blood pressure. But cardioselective beta blockers or alpha blocking activity make some good, but even carvedilol, their alpha blocking potential is very less than beta blocker efficacy. So in textbook, clearly shows even labetalol and carvedilol, their use alone is contraindicated. So we go on. Hemoglobin A1C is somewhat stabilized, but there is still increased the hemoglobin A1C. So I think when I see the hemoglobin A1C level over 9%, I think it's time to start insulin. So I asked co-work with endocrinology department. It is really good to change the hand and hear the second opinion. They show from time to time there is microscopic hematuria. So he took the computed tomography. This time I screamed. I find the large pheochromocytoma. So hormonal evaluation, there is epinephrine, adrenaline dominant type, but noradrenaline is still increased, and renin, aldosterone are increased. And PET scan, there is mass and there is no other finding. So in outpatient clinic course, echocardiography normalized after first episode of heart failure, marginally controlled blood pressure and pulse rate, responded to beta blockers. And diabetes mellitus progressively uncontrolled despite full oral medication. And incidentally, pheochromocytoma diagnosis after computed tomography due to incidental microscopic hematuria. In this point, I hope to ask your opinion. What time is the timing I can diagnose earlier than the 9 years follow-up?
Okay, this is open, and whilst everybody is thinking, I think it's very, very difficult in this case because you've never really managed to have hypertension until very, very late. So my question is, during observation of this patient, have you ever done either ambulatory blood pressure monitoring or home blood pressure monitoring, any out-of-office blood pressures? Because perhaps this could have picked up things earlier.
Yeah. Yes, I didn't think about doing ambulatory blood pressure because the antihypertensive medication regimen is not so heavy.
Yeah.
The usual 2 or 3 drug medication, so I didn't took ambulatory blood pressure monitoring.
Okay, any points? Yeah, we've got Gary.
Thank you. I don't know when you could have made this diagnosis. You had to get lucky, I think, to make it. But it's interesting, reflecting on the pharmacology of carvedilol, that she wasn't hypertensive until you improved her ventricular function to the point that she could sustain an elevated blood pressure. And then it was fortunate that a drug which is predominantly a beta blocker with a little bit of alpha blockade didn't increase her blood pressure further because she was predominantly secreting adrenaline when you came to get some catecholamine. So it's been a course which could have been very different if it had been a different kind of pheochromocytoma.
Okay, we have another comment. Please introduce yourself.
2 questions. We've had a lot of tests done, but what was her fundoscopy like right from the start and in subsequent examinations? And what happened to the raised PT, which was in the first testing done right at the start? She had a raised INR. Was it investigated?
Yes, the first, until this point, this timing, I didn't think she is hypertension patient, but a hypertensive heart failure patient. So regrettably, I didn't see the retina examination. So it is my fault. And can you ask me once more, second question?
The INR was raised right at the first initial INR, PT, prothrombin time.
PT is about 80%. So INR value is over 1, but less than 2. So 80% of normal range. So I thought that was part of congestive hepatopathy. And LFT and PT was normalized after discharge.
Thank you.
Okay, the right microphone, please.
So I have a question. Now we flashback her history. In the second examination, there is a T-wave inversion in EKG and small apical aneurysm, and there is enough reason to perform a coronary angiography because she has a diabetes and hypertension. So how about the cardiac enzyme or her symptom, or did you ever perform the
Yes, in the
coronary angiography?
very good question. In the first time, in terms of diagnosis heart failure etiology, I can do the coronary angiography in this patient, but in initial cardiac enzyme is completely normal. There is no sign of elevation. And second one is response is quite rapid. So based on these two findings, I ruled out the possibility of coronary artery disease.
Okay. So sometimes pheochromocytoma produced cortisol. So in the middle of the examination, her lab data, is there any hypokalemia developed or not?
No, there is no kind of hypokalemia because as I use the thiazide diuretics and I will check the natrium and kalium, but there is no range of derangement. Thank you.
Okay, so do we have the rest of the story? I think we're ready for the rest of the story.
So, but it took 9 years from first meeting this patient and final diagnosis, but all is related with pheochromocytoma. For example, diabetes is maintained 6 years, but after operation, there is no sign of any diabetes mellitus. So in this point, check about the prevalence of diabetes in pheochromocytoma. Pheochromocytoma is one of most higher prevalence of secondary glucose intolerance in endocrine disorder. So majority of patients have hypoglycemia, but usually mild course, and especially adrenaline dominant type is a more higher affinity for beta receptor. So by binding beta receptor, they increase gluconeogenesis and decrease insulin release. That two mechanism is the main mechanism of pheochromocytoma associated hypoglycemia. When I added sulfonylurea, only 1 tablet per day, her hemoglobin A1C level decreased by 2 points. It is unusual. Usually potence of sulfonylurea is only 1% hemoglobin A1C decrease. So that may relate the rejuvenating insulin release from the beta cell. So after find out the pheochromocytoma, at that time we did good. Alpha blocker, we covered the alpha blocker, and we sufficiently supplied 6 liters per day, 1 day before operation. So there is no hypotensive episode during operation. So adequate hydration is very important point. And regarding preoperative alpha blocking, there is still complex whether alpha blocker is better or phenoxybenzaimine is better. One of the good points of phenoxybenzaimine is BP control. But phenoxybenzaimine is not a familiar antihypertensive agent, and doxazosin is familiar. Doxazosin treatment was associated with less pronounced BP fluctuation. So in that case, we used doxazosin, but current standard treatment of pheochromocytoma in my hospital is phenoxybenzaimine. So gross specimen and some malignant portion and whole benign portion. So even there is some malignant foci, patient is very indolently make course of 9 years, and adrenaline dominant cyclic type pheochromocytoma causing transient heart failure and diabetes mellitus. And after operation, both conditions completely disappeared. So sure, follow up without any medication. So in the final discussion point, I would like to ask your opinion. What is the adequate preoperative prevention strategy between alpha blocker and phenoxybenzaimine?
Okay, so in our center we would have normally used phenoxybenzaimine because that's how it's always been done, but I don't think there is any evidence that one is truly better than the other. But it is quite good to lower blood pressure preoperatively, and as you did, maybe it doesn't matter which drug, but to truly control blood pressure to the millimeter during surgery to avoid any big blood pressure differences, both up and down. Any other opinions? They agree. They agree. Okay, there is one question that just came to my mind at this very moment. Has she had a pregnancy before? Because in a woman, occasionally, pheochromocytoma comes to light during pregnancy, especially if there are any procedures such as cesarean section, etc., sometimes dramatically. So was she ever pregnant or not?
No, she has no experience of pregnancy. 1 year before heart failure aggravation, she got hemorrhoid operation under local anesthesia, but happily there is no surgery of pheochromocytoma during local anesthesia and operation.
So I think in this case we need to blame the patient. She made it so difficult for you to make the diagnosis that I think you need to feel completely free of any guilt. Any other comments from the audience, please? No? So you have the final diagnosis, which we all agree with. And there are no more comments, so if you would like to summarize, and we'll be closing the session.
Yes, final diagnosis, adrenaline predominant cyclic training subtype, pheochromocytoma causing transient heart failure and diabetes mellitus. So through this conference, I hope to again keep in mind pheochromocytoma have really multiple phases. So in any case of clinical uncertainty, we think the possibility of pheochromocytoma.
Right.
Thank you very much.
Thank you very much. It's fantastic presentation. And could I thank all presenters? I think we had a very good, although not greatly attended session. We'll work on this for next time. And could we have all discussants, please, to give your names and emails to Denise. Thank you very much for attending this, and have a nice evening.